of interest and application. Then we've got some holidays coming up before long. A week from today, hard to believe, or maybe not hard to believe. I'm not sure which it is, but anyway, a week from today is election day. And of course, that's a state holiday in Montana, so we don't have class that day. But I'll do what I've been doing for a while, and Katie too has been doing, encourage people to vote if at all possible. There's still plenty of time to register, and U of M was going to hold a big registration day, and I'm not sure about the exact date on that. Maybe it's already happened. I'm not sure, but one day was sort of going to be an all-purpose sort of thing at the Adams Center, where you could go register and vote and get the whole thing done at one time. I'm not sure if that's happened already or if it's upcoming in just the next few days. Maybe somebody could take a quick glance at the schedule and see what they can find out about that. But anyway, there's a week to register. You can register, as we've talked before, clear into voting day itself. So that's pretty nice to be able to do that, although probably be a lot more convenient if you had that done ahead of time and didn't have to do a bunch of waiting in line. If you've been following this at all, the early voting in Montana as well as nationwide is just breaking records left and right. And I'm not sure of the exact numbers now, but I think we're somewhere in the range of 50 plus million nationally have already voted. And I think that's at least twice the rate at which that usually happens. So there's tremendous interest in this election for both local and national reasons, and a great opportunity for all of us to participate in democracy by being involved in the vote as we approach that time over the next week. So
today, it's today from 9 to 5.
Until 5? Well, that's fantastic. Thanks for looking that up. That's great. So just to reiterate for everyone, if you go to the Adams Center before 5 o'clock today, you can get registered, and I believe you can just go ahead and vote if you want to. So that's terrific. Thanks for digging that out. And it sounds like a nice opportunity, although I guess a lot of people aren't really on campus right now, so that maybe isn't quite as big an opportunity as it would be if we were more of us were on campus at this given time. But anyway, that's a neat deal. And if that doesn't work out for you, you can contact the Missoula County voter registration office to find out how you can go about registering between now and 1 week from today. Okay, so then the next piece of news, not really news to anybody, but just a reminder, I guess, is that we have third exam upcoming on Friday next week, not this week, next week. And that's the 6th of November. And I'll have to double check these things to make sure I'm correct, but I believe the time for this one is 3 p.m. And I think we're able to use the Urey Lecture Hall again, but I will also check on that to make sure that's the case, so that we're all showing up at the right place at the right time. We haven't made the final decisions yet about how many questions will be coming from each of us, but the format is the same: 50 multiple choice questions. Katie and I will both have questions on it. We just haven't determined exactly how many yet, but we'll let you know about that just in the next day or two, so that you have that in mind in terms of your preparations for the exam. And then remember that as we're approaching the end of the semester here, things get squeezed. So the fourth exam comes up pretty quickly. I believe it's on the 20th. Comes up pretty quickly after exam 3. So we'll get that graded and the results back to you so you know where you are well ahead of time in terms of heading into the conclusion for the fall semester of the pharmacology course. So there we are. That's a quick look at schedule. And now I'll back off again for just a second and see if anybody came up with questions or comments while we were thinking about some of these schedule matters.
Hey Keith, would you be willing to discuss the extra credit part of it? As
Yeah.
in the fundraiser donation, is it something that we need to be a part of, like a fundraiser that we need to purchase something from, or do we need to run a fundraiser?
You know, usually the way we've done this in the past is that if you were a part of a fundraising activity, that counted for extra credit. So we usually don't do a lot of that, but if somebody has, you know, a standard fundraising activity, we could certainly consider doing that. The thing is, we have to be fair, and everybody needs to be able to have the opportunity to partake in that extra credit activity. So it would have to be something or some things in which one way or another, everyone in the class was able to partake in if they wanted to do so. Does that help out?
So, for example, I raised money for the food bank through my work. That wouldn't count.
I can't do individual things like that. It's more along the lines of, and I think we've done a lot more of this in spring than in fall. But if there's a fundraiser available to the entire school of pharmacy, be it a run or a walk or something along those lines, we've typically done that. You have to be real careful about making sure that it's an equal opportunity thing for individuals. Thanks for bringing that up. It's good question. Okay, well, the first slide here, which I've labeled Grace, and I can't remember. I wish I could take claim to this slide, but I can't. Somebody gave it to me a few years back, and I just think it's just one of the great slides out there, where this child is offering some help to Kitty Cat there in the rain. So if we're in need of a relaxing moment, I think that's a pretty cool slide to refer to. So the first part of this is going to be very much repeat from the great job that Katie did on Parkinson's disease already. So I don't think there's anything new really in this segment, but to be consistent, Parkinson's is, you know, and fairly commonly occurring neurodegenerative disorder. I've decided to spend a little bit more time with it. And, you know, if there's anything that I say that contradicts things that Katie had to say, trust Katie, not me, because she's a much sharper tack than I am these days. But anyway, neurodegenerative diseases is a huge overall topic for a lot of different reasons. But one of the main reasons is that in the United States, and particularly other developed countries throughout the world who have aging populations, seeing increased incidence of a variety of neurodegenerative disorders. And only a little bit along those lines are we attempting to tackle in this particular lecture, but it deserves our attention. The really tough thing to swallow about it is that in no case, including Parkinson's, do we have really the type of pharmacotherapy that we would like to have. And in some areas, we have literally none at all. And this is despite huge amounts of research that have gone into these areas over the last half century. It was anticipated quite some time ago that with aging populations, there were going to be problems associated with a variety of degenerative disorders. And so the research state kicked up rapidly some time ago. But these are extremely difficult areas for research and for clinical practice. And so there's nowhere near the type of progress that I think most people in the field would hope that we have had at this particular time. As noted on this slide, this historical recount of Parkinson's disease, notice that James Parkinson identified the associated phenomena with Parkinson's in the range of 200 years ago, which is rather remarkable. It took another about 150 years or so for there to be substantial recognition that dopamine, the neurotransmitter dopamine, plays a big role in Parkinson's. It's certainly not the only matter, and there's no question in the world about the problems that arise with respect to dopamine. Whether the emphasis that's been placed on that over these years is in the right direction in terms of understanding the underlying etiology is another matter. And to this day, we really, in many of these neurodegenerative disorders, including Parkinson's, really don't know the fundamental neuropathology that's occurring that initiates the syndromes and leads to, for example, the problems associated with dopamine in the case of Parkinson's disease. So there's still a long way to go in terms of understanding what the underlying bases of these disorders are. And until we know more about that, we're probably going to be stuck as far as being able to really do the type of pharmacotherapy and other types of therapy that's necessary to really directly address these disorders. Although you never can tell when something will arise that we didn't really anticipate and that will maybe just almost by accident develop some type of treatment that's better for Parkinson's as well as the other degenerative disorders. So you can see in the latter part of this slide that replacement therapy for dopamine in Parkinson's disease was recognized back into the 1950s and 60s. And although there have been some developments in terms of pharmacotherapy, particularly in the case of Parkinson's since then, in many ways, the progress has been exceedingly slow. So just to quickly recount, what we're talking about here in terms of observable symptomology, tremors, slowness in movement, problems in initiating movement, a lot of muscle weakness and rigidity, problems associated with balance and orientation, a particular aspect of facial expression, and to some degree some problems associated with the spine. One thing that I haven't emphasized on this slide, and I really should redo it to emphasize it, is that these movement related things is as prominent as they are in Parkinson's aren't the only story. And there's considerable involvement of mental capacity, cognition, and often when we're sort of reading about what's going on with Parkinson's, the movement related aspects, which are so important, but we tend to sort of dominate our discussion along those lines and sort of leave out the more mental side of it. But in some individuals, mental deterioration is as great or even greater than the movement-related phenomena that we so commonly talk about. So it's a systemic disorder that involves the central nervous system as well as all the other organs to some degree or another in the body, and therefore the representation of symptomology and phenomena is rather widespread as the disorder progresses over a number of years in many cases. So this is just a little pathohistology associated here. I think the one thing that I'll point out is that not only are neurons involved, but astrocytes are involved. So just as we are talking about sort of, the widespread nature of the disorder, it goes beyond just neurons themselves. And a lot of people have worked fairly extensively over the last decade or two in terms of understanding what role glial cells have in the overall problems associated with Parkinson's. So as you probably remember, the major problems associated with the movement aspects of the disorder occur in the diencephalon, particularly the basal ganglia, and the ultimately the deterioration of dopamine-containing neurons is a big deal as far as this motor regulation is concerned. Notice at the top of the slide the emphasis again on initiation and execution of movement. This sort of intentional aspects of this are substantial, and although at least for a while in the early going with Parkinson's, the gross motor movements can be initiated, it's difficult in doing so, and the individual who has the disorder has challenges as far as getting those movements going, and part of that then relates to the sort of the slowness, the bradykinesia that we were talking about in the previous slide. So there's slowness in terms of movement sorts of things, and slowness in terms of mental sorts of things. Well, this was greatly covered by Katie, so I won't linger here at all, but the involvement of dopamine, acetylcholine, and GABA is well recognized in Parkinson's, as well as some of the other disorders that we're going to talk about, although not exactly in the same way. So, what this comes down to in terms of classical pharmacological treatment with respect to Parkinson's is finding ways to enhance the dopaminergic component and basically pull back on the acetylcholine component. So, classical cholinergic blocking drugs of the atropine class are part of the therapeutic approach, from the cholinergic side of things, as well, of course, as dopamine over in the dopaminergic pathways of the globus, of basal ganglia. So, here's some of the players that Katie talked about. Dopamine itself, of course, we all recognize anymore that we can't get dopamine across the blood-brain barrier, at least not very well. So we have to start with a precursor, dihydroxyphenylalanine or DOPA. Carbidopa, which is a metabolism related substance, is frequently joined with DOPA itself in this phase of treatment. So there's sort of really, two major avenues that are going on here: dopamine itself, and then the metabolism of dopamine. So recall that even though you can't get dopamine readily across the blood-brain barrier, you can get that precursor DOPA across. Although even there, it's rather inefficient, and very small amounts of DOPA manage to penetrate the blood-brain barrier, which is one of the reasons why you have to pay attention in many cases to some of the metabolic sorts of things, because if you're going to have a decent amount of DOPA that crosses the blood-brain barrier and then gets converted to dopamine in the brain, you need to do everything you can to enhance the ultimate concentrations of dopamine. So this slide just continues to sort of talk about that inefficiency of process of getting the DOPA into the brain, and there can be food related phenomena associated with this. If you associate the DOPA administration with a high protein meal in which ultimately there's a lot of amino acids released from that from the protein, then there can be competition for the uptake sites in the transporter between DOPA and those other amino acids. So some attention does have to be paid to the time and environment of the administration of the DOPA. We're talking in terms of time frames here. We're talking about hours, basically. Peak concentration there in the range of an hour to half-life in about the same time frame. So typically multiple administrations have to occur during the day, and so frequently in the range of 3 to 4 administrations occur throughout the day. So the carbidopa levodopa combination is a very common one in initiating therapy once Parkinson's has been recognized, and this, I say here that peripheral metabolism is reduced by carbidopa, ultimately resulting in about 10% reaching the brain. That's overly optimistic. I should change this slide to make it more consistent with the previous slide. In the range of just a few percent actually reaches the brain. But it's often fairly successful in terms of treating some of the more common motor-related phenomena, such as the slowness of movement. But the levodopa-carbidopa combination also does help out on the cognitive side of it in individuals who are having problems associated with cognition. Often have at least brief increases in their ability to think. associated with this pharmacological intervention. So pharmacology does often seem to occur in about thirds. And you'll notice that in that last statement in this slide, in that about a third of people will respond quite nicely to this combination. Another third will respond, but not with the efficacy that the earlier group did. And then unfortunately, there's about another third that really doesn't respond at all. Now, some of that may be associated with the fact that Parkinson's, like many of these other CNS-related disorders, is really a spectrum of disorders. I tend to talk about it like there is the Parkinson's disease, but that is really an oversimplification. And the reality is that there are subtypes of the disorder, some of which probably haven't even been recognized yet, which make for intervention pharmacologically difficult until we know what the differences are between those various subtypes. So some of the patients who don't respond well to this are probably because there's a different subtype of Parkinson's disease as compared to the people who are partial responders or full responders. So sometimes, typically later rather than earlier, a more direct approach to dopamine is taken, because there are many other drug substances which are dopamine-like in their actions. And I won't run through all these, but I'll mention particularly a couple of the classics, including at the top there, bromocriptine, which is a very substantial dopamine receptor type 2 agonist, and then apomorphine on the bottom part here, which is another powerful dopamine agonist. Despite what I might say at some points about these agents as being relatively well tolerated, that's again a bit of an over exaggeration on my part. And one of the things that holds back the direct acting dopamine receptor agonists is that they're pretty powerful drugs. I probably shouldn't say this, but to some degree they're kind of nasty, and therefore, I mean, they can be quite helpful in addressing the dopaminergic phenomena associated with Parkinson's, but there's also a lot of complexity that comes along with the adversity of these agents. So kind of a related theme to the DOPA earlier, except this is a more direct deal. These agents are capable of traversing the blood-brain barrier and therefore can be used as direct replacements of dopamine itself. So then the other aspects of this, and again, Katie covered this well, so I'll just breeze by it, is trying to reduce, in the case of DOPA itself, we want DOPA to remain DOPA until we get it into the CNS. Once it's in the CNS, we want it converted to dopamine. And sometimes we kind of, it's easy to get confused about that. So monoamine oxidase and COMT are two really prominent enzymes associated with metabolism. And so that also is part of the pharmacotherapy, which we've already seen a little bit in terms of discussing DOPA and the combination drug there. But anyway, basically think about this in the overall context of what Katie had to talk about in terms of sort of dopamine itself, and then the metabolism of dopamine, drugs that also mimic the action of dopamine. So other agents, amantadine, I'm not going to really say much about because we really don't understand well at all why it's useful, but it is in some individuals. But I think the important part of this next slide has to do with the antimuscarinic drugs, of which benztropine, the first one on the list there, would be my recommendation for recognition in this whole deal of where you see benztropine, classify it. It's an atropine-like drug. Further classification is it's often useful in terms of treating the excess cholinergic tone that occurs in Parkinson's. So too little dopamine, we try to enhance that. Too much acetylcholine, we try to reduce that down. So hopefully that didn't confuse you too much from the clarity that Katie had produced. And so I think we'll move on now into Huntington's. Huntington's is another very prominent motor-related disorder. It's also been recognized for a long period of time. You see involvement of dopamine, acetylcholine, and GABA once again, although again a little bit differently than what we saw back with Parkinson's. And so whereas Parkinson's, the problem is not enough dopamine. In many ways, in Huntington's, the problem is too much dopamine. Let me see if I can emphasize for you here. So this next slide, the overactivity in the nigrostriatal pathway is in many ways just that flip side of what we saw back there in Parkinson's. Treating the overactivity is problematic. And that'll make more sense to you as we talk about two of the most common approaches that are used in a pharmacotherapeutic sense, including our old friend reserpine, which we've talked about a number of different times in a number of different contexts, which you know is a depleter of dopamine stores, but also is very general in its actions. So it depletes concentrations of other monoamines also. Therein lies some of its adversity. So reserpine, is very efficacious in terms of depleting neurotransmitter, and in some ways too efficacious. And so it's a tough drug, but we're in tough circumstances with Huntington's. So some of the adversity has to be taken into account as we are sort of up against the wall in terms of how to decrease the dopamine, the excess dopamine in the system. Another approach that is taken and equally problematic, and we'll talk about it more tomorrow when we're talking about the antipsychotics, is the utilization of powerful antipsychotic drugs like phenothiazines, not for their antipsychotic purposes, but because they're dopamine receptor antagonists. And I think I might have mentioned sometime in passing in the last few weeks that as far as I know, there are no known antipsychotic drugs which are not dopamine blockers. And the phenothiazines itself, of which chlorpromazine is the prototype, and we'll talk about that as prototype tomorrow. Haloperidol is a slightly different chemical. It's a butyrophenone, but the butyrophenones and the phenothiazines are both very, very capable dopamine receptor blockers. But again, they bring a lot of adversity along with them. And I'll detail that more again tomorrow when we're talking about the antipsychotics. So whether we're talking about depletion of dopamine or blocking dopamine, we're talking about the ability to do that, but only with challenges associated with that. So, what's going on at the underlying level as far as, let me just stick with Huntington's here. I was thinking that I had another slide in there I missed this slide, and I want to stop there for just a minute, because it's really not right for us to talk about treatment of Huntington's without knowing, what the problems are. But once again, that the second bullet point there addresses the motor and the mental problems associated with Huntington's. So progressive jerking is basically what that means. So there's it's a little bit different than the tremor like sorts of things that occur so frequently in Parkinson's. You can get pretty substantial tremors, as well as a deterioration of the ability to think. So there's undisputed cognitive deficits associated with Huntington's, which then are frequently treated as we were talking before. I keep hitting my mouse here, and that's why we keep advancing unexpectedly. My mistake on that. So I'm sort of running too slow here. Basically, hopefully you got the idea that we're looking at the other side of things as far as dopamine is concerned compared to Parkinson's. Lou Gehrig's disease is another extremely problematic neurodegenerative disorder to treat. The motor deficits here basically have to do with the spinal cord, as you can see in this particular slide, as well as cortical neurons higher in the central nervous system. There have been a ton of theories associated with why this degeneration occurs. No good landing as far as that is concerned right now, but there about mid-slide, I would like to emphasize the idea that oxidative damage is frequently associated with the motor deficits that occur in ALS, and so there's been a lot of research done in that area. And if that's a particular area of interest to you, let me know. Fernando Cardozo, who was a previous faculty member in our department, and who really I owe this presentation to, and would be presenting this in a better way than I can if he was still here, has an absolutely state-of-the-art publication in a book on the oxidative aspects of Parkinson's in that particular case. But oxidative damage is of significance in a number of these other neurodegenerative disorders. In this particular case with Lou Gehrig's that we're talking about now. So much to the betterment of Colombia, the country of Colombia, which Fernando is from. Fernando has returned now to Colombia, and so he's doing his research work there now. But a big loss for us, because he was really an outstanding neurodegenerative disease researcher. And so if you'd like more detail on the oxidative aspects of neurodegenerative disorders, let me know, and I'll get some reading for you there. So the address of ALS is a challenging one. Here's a particular drug of importance that basically has to do with the glutamate system. And note there from a mechanistic standpoint that it's an antagonist at NMDA and kainate glutamate receptors. Treatment in this particular fashion is, a little bit useful, but in no way does it address the underlying etiology. So the ALS then continues to progress despite the treatment. Other approaches that can be used to treating the overactivity that's occurring in the system include utilizing the GABA B agonist baclofen, which is a classical drug in this area. It's been around for a while, and sort of rather than addressing glutamate, this is sort of addressing GABA. I would also like to note that, and perhaps a little bit later in the course, we'll be able to address MS a little bit. Here's an example of a drug that's utilized in both ALS and MS in certain cases, and more familiar substances to us, including GABA-related agents like the benzodiazepines are often utilized. Well, Alzheimer's is a real problem, and related neurodegenerative disorders to Alzheimer's. It's a real problem because really we have almost nothing that really works well. And I'll say a little bit about some things that work a little bit, but nowhere near to the level that we need, considering the incidence of the disorder in the aging population. So you see those staggering statistics there. And by the time an individual reaches 85 years old, almost half of the population are suffering from Alzheimer's or some related dementia. And here's just some more pathohistology, which I guarantee you I will not ask anything about on the exam. But the presence of plaques of one type or another is very, very common in Alzheimer's and other types of dementia. Here's another example of it. And I think it's interesting to note that the words that are used here in describing how individuals take a look at the pathophysiology of Alzheimer's are sort of kiddingly, if one favors the amyloid side of it, the theory is called Baptist theory. And if you favor the tau sort of the problems there, then the Taoists. So sort of some cute little words, but definitely not acute disorder. So widespread damage occurs in Alzheimer's, and a variety of neurotransmitter substances are involved in that particular aspect. The one that has been especially addressed is acetylcholine. And so our friends, the cholinesterase inhibitors, which we encountered back there in talking about the parasympathetic side of the peripheral nervous system. So we know a little bit about cholinesterase inhibitors already. It's a different group of cholinesterase inhibitors that are typically used in Alzheimer's relative to what you see back in the parasympathomimetic indirect acting category, but nevertheless cholinesterase inhibitors, which gives you some insight right away going, oh boy, we know what those agents are like. So when we pick up with this and finish off with this tomorrow before moving on into the antipsychotic drugs, we'll talk about the specific cholinesterase inhibitors that have been utilized in Alzheimer's and the degree of their efficacy versus their adversity. So we're out of time. If anybody has any questions and would like to linger, Katie and I will be here for a few minutes. And if not, we'll reconvene for our doubleheader tomorrow morning at 11 a.m., finish up on degenerative disorders, and move into the realm of psychoses. Thank you very much. Have a great day. Try to stay warm if you can. And register to vote if you haven't already.